guys. My name's Sanjay Gupta. I'm a consultant cardiologist. I work in York. And today I wanted to talk to you about bleeding. In particular, I'm interested in talking to you about the subject of the risk of bleeding in people who take anticoagulants. Anticoagulants, as you know, are medications that a lot of people take to try and minimize the risk of clot formation within their bodies. In particular, patients with atrial fibrillation often have to take anticoagulants, be those warfarin or the newer agents called the NOACs. And this video is probably particularly relevant to those people. Now, in an ideal world, what you want to do is you want to have an anticoagulant which minimizes the risk of strokes, i.e. clot formation, but does not cause any increase in bleeding propensity. Unfortunately, however, there are no such agents. Anything that stops clots from forming will undoubtedly increase the risk of bleeding. They don't necessarily cause you to bleed, but if you were unlucky enough to bleed, they will reduce your blood's ability to clot and therefore exacerbate bleeding. And therefore, it is a big concern when you're prescribing anticoagulants to anyone that you don't do any harm, most of the time inadvertently, but you don't want to do any harm. You want to give the patient the benefit of stroke protection, of protection against strokes or clots within the body, but you don't want to inadvertently expose them to a much higher risk of bleeding. Okay, and this is a big thing because for doctors it's a real worry because, you know, when you prescribe someone anticoagulants, they will never really know whether that anticoagulant has prevented a stroke from happening or not. You just have to assume that it's doing some good. You don't know for sure, because if you haven't had a stroke, how would you know whether you would have had a stroke if you weren't taking those medications? But the risk of bleeding is something, or bleeding is something you definitely see in front of you, i.e. you take a tablet that a doctor gives you and the doctor says, well, it'll stop you from having strokes, and you take it and you don't know whether the stroke is prevented or not. But if that tablet exacerbates bleeding, then you know about it, and you automatically blame it on the tablet, which is a reasonable thing to do. And for a lot of doctors, you don't want to do harm, because that harm is something that the patient can see and experience in trying to do some benefit, which the patient will never necessarily realize. Okay. So researchers have been trying very hard to try and work a way of assessing the patient to assess their bleeding risk before they start anticoagulants. The idea being that if you are at a very high risk of bleeding, then perhaps the risk of the anticoagulant, prescribing the anticoagulant, will outweigh the benefit. And there is a scheme now available in common practice and is being used by a lot of people, called the bled scoring system, which people use to calculate the bleeding risk. And I just wanted to talk to you a little bit about this, because it is, in my opinion, not being used as it was designed to be used. Now, the HASBLED, H-A-S-B-L-E-D, is a mnemonic. Okay, HASBLED, the H stands for hypertension, high blood pressure. The A stands for abnormal liver or kidney function, and the idea being that if you have abnormal liver or kidney function, you're more likely to bleed anyway, and therefore if you take an anticoagulant, that risk is increased. The S stands for previous stroke. Okay, and if you have had a previous stroke, you're more likely to bleed, but of course you're also more likely to have a stroke, conversely. The B after that stands for bleeding in the past, major bleeding or predisposition to bleeding in the past. Of course, that would increase your risk of having more bleeding if you've had. The L stands for labile INRs. Now, these are patients who are already taking warfarin, and if they find that their INR levels, which is a measure of how well anticoagulated they are, is very high or very low, then that undoubtedly either increases your risk of stroke if it's too low a lot of the time, but if it's too high, then undoubtedly increases your risk of bleeding, because you don't want to be taking taking more anticoagulant than is necessary to achieve the desired effect, because of course it could anticoagulate you even more than you need to be anticoagulated, and therefore increase your risk of bleeding. And we know that if you have if you've measured the number of INRs you've had and then calculate the number of INRs where your INRs are below 2 or above 3, and work out a percentage, that thing is called time in therapeutic range. So how many times are you out of that INR range of 2 to 3? And if it's less than 60%, then undoubtedly either your stroke risk is higher or your bleeding risk is higher, depending on whether it's too high or too low. And then there's age. After labile INR, there is age. So if you're above the age of 65, you're more likely to bleed. Increasing age means you're more likely to bleed. Then there's the D stands for drugs, okay? And drugs means, are you on any other medication that can increase your risk of bleeding? So in particular, people who take antiplatelet agents, which also work on the platelets, which are important to prevent clotting. So aspirin, Brufen, Voltrol, those kind of things, they increase your risk of bleeding. And then finally, there's the D also stands for alcohol. So alcohol and drugs, that's why the D. So if you are drinking more than 8 drinks of alcohol per week, then that increases your bleeding risk. Now, the problem is that when a lot of doctors are trying to work out your bleeding risk, they use the HAS-BLED score as a scoring system. So they calculate how many ticks you get, and if you get above a certain number of ticks, usually they say if you have over 3 ticks, then your bleeding risk is high. And people use that and say, well, okay, you score highly, you shouldn't have an anticoagulant. And this is where I think there is a slight misunderstanding. The HAS-BLED system was never really designed to be a scoring system. It is designed to be an aid memoir for doctors to try and assess those factors that can be modified before anticoagulation is started to facilitate safe anticoagulation. I.e., let's go through this, okay? H for hypertension. Well, if you have high blood pressure, you're more likely to bleed, but equally well, if you have high blood pressure, you're more likely to have a stroke. So just because you have high blood pressure doesn't mean that you score highly. If you have uncontrolled high blood pressure, i.e. blood pressure readings of over 160/80, then most people would say, well, yes, we should try and control the blood pressure a bit better, get it down to below 140. And then once the blood pressure is better controlled, then let's start anticoagulation. So it shouldn't deter someone from anticoagulating, but it should allow doctors to just be mindful that the blood pressure is excessively raised, and a higher blood pressure increases the risk of bleeding. So let's control it, but let's not let it put us off anticoagulating the patient. Then there's abnormal liver or renal function. And again, if you have abnormal liver and kidney function, it is well worth looking into why. Okay, because a lot of the anticoagulants are broken down by the liver and the kidneys, and in addition, liver disease thins actually makes thins your blood, and kidney disease can cause an abnormality of your platelet function, so your platelets don't cause a clot to form as quickly. So it is important, if you have liver or kidney problems, that these are checked out, okay? I don't think it's reasonable just to accept it and start a patient on anticoagulant. It is worth going and seeing a liver or a kidney specialist and getting that investigated and treated to the best possible way. before an anticoagulant is started. In some people, you may just have to accept that risk. You know, if you've been assessed by a specialist and they say, look, you know, you have abnormal liver function tests, but I don't think I can do anything to improve them. Well, then that's a question that you have to raise with that doctor and say, do you think it's safe for me to be on an anticoagulant? Okay. Stroke history. Well, of course, you know, um, you're trying to prevent a stroke. So if you've had a stroke, you're more likely to have more strokes. So you are a much higher risk of having strokes anyway. So you definitely need the anticoagulant. If you've had a stroke, yes, you are more likely to have a bleeding complication as well, but that should definitely not deter you from going on an anticoagulant because your risks of having another stroke are much greater anyway. Prior major bleeding or predisposition to bleeding, again, that is to serve your doctor to try and work out whether the predisposition to bleeding has been addressed, and if not, let's address it before we decide to start you on an anticoagulant. Again, none of these things should put you off anticoagulation. These are just things that need to be addressed before starting anticoagulation so that you are anticoagulated as safely as possible, where you're getting the benefit of the anticoagulant without being exposed to additional risks of bleeding. Labile INR, definitely, if you have INRs which are very variable, then your doctor should definitely look and try and work out why your INRs are variable. In particular, if you have addressed things like, you know, could it be that you were ill at that time and that can cause the INRs to be go up and down? Could it be that you were drinking excessive amounts of alcohol, or you had a problem with your liver or kidneys, or you were on additional medications which could cause the INRs to go up and down? If you have anything like that that is causing the INRs to go up and down, that needs to be removed from the equation so that your INRs are static. If you cannot, or if you still have very labile INRs, then obviously a better thing is to go on an agent which isn't affecting your INRs in this way, i.e. a NOAC. Um, you know, and that would be one good reason to be considered for anticoagulation on a NOAC rather than on warfarin. Um, Age, well, of course, the older you get, the more risk you have of pretty well much everything. You have a higher risk of bleeding, but of course you have a much higher risk of stroke. So I wouldn't let that deter me from starting anyone on anticoagulants. Medication usage. Now, this is an important one because a lot of people are given aspirin or Brufen, okay? And while some people need Brufen, your doctor should really evaluate whether you really need these agents in addition to your anticoagulant, because undoubtedly any anticoagulant and any antiplatelet, sorry, that's Bluebell, any anticoagulant and any antiplatelet, when you combine them together, will cause increased bleeding. Now, a lot of people go on aspirin because aspirin used to be dished out like Smarties, but we've started realizing that, you know, just taking aspirin for the sake of taking aspirin is no good. There has to be a very, very valid reason for taking aspirin. And it's also worth saying that if you are then starting on an anticoagulant, it may well be that the anticoagulant covers some of the risks that the aspirin's meant to be covering. So your doctor will need to think about it and, where possible, discontinue the antiplatelet agent. There are some people, for example, if you've had stents done, you know, a week ago and you need to be an anticoagulant, maybe you just have to take the risk of being on both. But wherever possible, if that risk can be modified, then that's a good idea. And then finally, there is the alcohol intake history. Okay, so if you are drinking excessive amounts of alcohol, and that is defined by more than 8 drinks a week, then it is a really good idea to cut that down, because reducing your alcohol intake will reduce your risk of bleeding, and that would then allow safe anticoagulation. So the whole idea is, you know, you're taking an agent which has benefits, but also risks, and there are certain things that can be done to modify that risk so that you can get the maximum benefit without exposing yourself to additional risks. So I hope this was helpful. I'm sorry I'm in a bit of a makeshift office at the moment because um, uh, we're trying to clean up. Anyway, so I hope you found this useful, and I'll pop my website is www.yourcardiology.co.uk. My Facebook page is yourcardiology@gmail.com. You just have to type that and you'll find me. There are lots of Sanjay Guptas, as you, as I'm sure you know. And then, yeah, and that's about it. So if you need to get in touch with me, come on over. I try and talk to a lot of people on my Facebook page. Equally well, you could send me an email. I'd love to listen to you. I'd love to hear you. And I'm grateful to all those people who share my videos, particularly you, Steve, who kindly share my videos on Health Unlocked. I do go and um, I wanted to thank Elaine and Jeannie, Jean, who say the nicest things, and I really appreciate it. All right, all the best. Take care.